So, as many of you know from last month, maybe, this topic is very, very near and not so dear to my heart. If you heard the testimonial last month, I have a stent that failed after 7 years. And really, it was only then that I decided I should find out more about how I can keep it a healthy stent. Let me ask some questions first. Raise your hand if you have a stent in a coronary artery. 1, 2, 3. Susan, do you? I don't think she does. Rodney, do you?
No.
Okay, so 1, 2,
it's
3.
a no for me.
3. Okay. Do you know what kind of stent it is? Mine is a bare metal stent. We'll hear about drug eluting, metallic alloys. They have a magnesium one now that dissolves, and a 3D printed polymer one, which is coming, which also dissolves. Did your doctor tell you how long your stent would last? No, mine didn't either. Has your stent ever been evaluated after placement for problems like restenosis? That would be no for me either. Okay. Was your calcium score explained to you? Not a bit. Yeah, me neither. And was anything said about the different foods to eat to keep your calcium score low? Okay. Well, good, because we'll find out the answers to some of these questions from 2 different doctors. We'll learn what stents are, why they fail, and what the best meal is to clear out your arteries. Although I found these doctors from a search on the Mended Hearts National website, they have not spoken to Mended Hearts or been vetted by Mended Hearts. So as with anything, buyer beware. But because of that, I'll tell you probably a bit more about their qualifications than I usually would, and why I chose them over the others on YouTube. I mean, there are a bazillion people, well, at least 12, that want to tell you what to eat, but not necessarily so you can keep your calcium score low. The first doctor has more than 1 million viewers on YouTube. His online channel is called Heart Matters. Dr. Peter Barlas is a Melbourne-based cardiologist who takes a holistic approach to the treatment of people with cardiac conditions. Professor Barlas is a pioneer in the field of interventional cardiology, dealing with treatment of blockages in the arteries. He has an active research interest in the study of heart disease and the use of optical coherence tomography. I had never heard of this. A highly detailed camera that is inserted into the arteries of the heart to look at fatty cholesterol buildup and to examine the stents once they're inserted. He introduced this technology into Australia, and you'll know by his accent where he's from, after completing his PhD in Thorax Center in the Netherlands and the Royal Brompton Hospital in London. He continues to publish journal articles and is frequently invited as a speaker to both the national and international cardiology conferences. He also sees patients with every kind of heart disease, including coronary disease, heart failure, arrhythmias, and valve disease. He's also in the second video, and he will explain the 3 categories of why stents fail. Modern day stents are extremely safe, but there are several important issues that can arise. And he gives us an overview of some of these reasons that lead to stent restenosis or thrombosis. And lastly, a Dr. Eric Berg will give us something we can do to help our arteries. Dr. Berg has over 11 million subscribers to his YouTube channel. He explains the reasons why each of the vitamins and foods clear out our arteries and a connection with the bacteria in our mouth. So let's see, he studied to be a chiropractor who specializes in healthy ketosis and intermittent fasting. He's the author of a best-selling book, The Healthy Keto Plan, and is director of Dr. Berg Nutritionals. He is no longer a practicing chiropractor, but focuses on health education through social media. So this is what he does. So I will, let's see, I guess I should share a screen, right? And we'll go to this one. Screen. So, and I'm going to put the words on the screen, but whoever did this didn't understand what he was saying with his accent. So you'll see stent written a very funny way.
Ballas, a cardiologist. Now, today's topic is all about stents and these little devices that we use to open up blockages in the arteries around the heart. So we're going to talk about what they are, what does it mean if we do have one, and how do we look after them. Now, there are many of you out in the community that have had stents, and I have a lot of questions being asked about what are these stents, what are they made of, and how does it affect my body once the stent is inside. So
Can everyone
today
hear
we're
me?
going to focus on these devices and why they are used and what are some of the things you should know about. So stents are put in through a procedure that we call angioplasty, and this is a procedure that we undertake when we perform an invasive test called an angiogram, and we've had a separate topic on what an angiogram is, so please do go back and have a look through the videos on what angiograms are. But these tests are picture tests using x-rays to visualize the arteries around the heart, to look for any blockages or narrowings that may happen as a result of the buildup of cholesterol or this fatty material called plaque. Now, that can develop inside the arteries of the heart, and obviously the arteries around the heart serve a very, very important role. What they do is they help supply nutrients to the heart muscle to allow the heart muscle to beat as it does, 70 times per minute, delivering nutrients and blood and oxygen to all our body. But of course, if there is a buildup of this cholesterol plaque, then you get less blood flowing to the muscle, and that can cause symptoms. And you might have heard of a term called angina, and that's typically a condition whereby you might have some tightness in the chest, going down the arm, up in the jaw, which can happen as a result of exertion or pushing yourself, climbing upstairs, going up inclines. The blockages can also build up rather abruptly, very suddenly, in the form of what we know as a heart attack. So placing these devices in, called stents, can be life-saving in that situation. The coronary stents are placed through a procedure called an angiogram, where we place a little catheter, a little tube, often through the wrist artery. From there, advance some catheters up to the heart and inject dye, visualizing the arteries, looking for any narrowings. If there is a significant narrowing and potentially if this is, typically more than 70% or so narrowed, there is a consideration for using these stents to open up the artery, to prop open the artery and then restore blood flow. Now, it's not the first thing we do. When we diagnose somebody who might have these blockages, depending on the clinical scenario, there might be tablets and medications and just lifestyle factors that your doctor might recommend. But in some patients, it can be very useful to improve symptoms that they might be experiencing and their quality of life by placing one or multiple of these devices called stents to open up the blood flow and restore blood and oxygen getting to the heart muscle so it can do its own thing. Placing a stent is used to treat buildup of plaque around the arteries of the heart and thereby improving blood flow and reducing symptoms. Now, placing a stent is not for everybody, and discussions with your doctor are paramount here and your cardiologist to look at whether the stents are the best thing for you. Do you need to have a stent, firstly, or is there an alternative therapy? Of course, medications and lifestyle changes addressing the risk factors, but also whether coronary artery bypass surgery may be more appropriate for you. And we're going to have a separate episode on exactly that, in terms of what is bypass surgery, how is it performed, and why might it be useful for you. Traditionally, stents were not the first thing we started implanting in the arteries. And when we started developing what we call intervention, and that's what I am, an interventional cardiologist, which essentially means I have had formal training in how to tackle the arteries and how to unblock the arteries using these stent devices. But we traditionally used to put a balloon in, simply popping a balloon through the catheter that we do an angiogram with, opening up the artery, squeezing the cholesterol open. But unfortunately, just placing a balloon itself means that the artery and the plaque buildup develops rather quickly. So it wasn't a long-lasting procedure. And that's when stents arose. Stents came around because we used to find that when we placed a balloon to open up the artery, the results were not long-lasting. And we thought, well, something needs to be there long-term to actually restore blood flow and actually keep the artery open. Traditionally, stents have been made of metal, and you might hear of various alloys such as stainless steel, cobalt, chromium. And these metals are very, very thin devices, sometimes even 60 to 70 microns thin. And these act like a spring, like a scaffold that goes into the artery at the site of where the blockage is and opens the artery up. And you can imagine by opening the artery, we restore proper blood flow and symptoms improve. Or if there is a clot forming in the artery as a result of a heart attack, the stent can treat that area, open the artery and restore blood flow, thereby minimizing any long-term damage to the heart. Now, stents are traditionally made of metal, and there are two types of stents that you may have heard, one being a bare metal stent and another being a drug eluting stent, or a DES. Now, what does that all mean, and why do we need these various stents? Well, again, the bare metal stents were the first generation stents that were developed. Essentially, they were made of a metal, like a spring, that was used to prop open the artery. But what we found with bare metal stents is that over time, the body was often unhappy having this device inside it, I guess a foreign material. And sometimes there would be a reaction or a type of healing response where the body actually even tries to reject the implant or the stent. And that can cause a process known as restenosis, or re-narrowing inside the stent, thereby developing more symptoms because of a repeat blockage. More worryingly is also a complication called thrombosis, or stent thrombosis, whereby the cells in our blood that are traveling through the artery can clump on the stent and develop an acute clot, causing a blockage inside the stent. So, of course, there have been many changes in design of stents, in the materials of stents, in how they behave and perform inside an artery. to look at reducing all these risks of stents long term. And about 2002 and 2003, we started implanting these newer generation stents at the time called drug-eluting stents. Now, the difference between a drug-eluting stent and a bare metal stent essentially means that we had the same material, same stent, same metallic scaffold. However, the stent was coated with an immune modulating drug, and that drug is released over a period of a few months into the bloodstream and into the artery wall to reduce the body's reaction against the stent. So you can imagine it's like an anti-inflammatory drug that is coated around the stent, which reduces that reaction and reduces the likelihood that your body will reject the stent, or there will be restenosis or re-narrowing inside the stent. So that was a very, very major advance back in 2003. And the stents since then have continued to evolve and to develop into what we have now, the latest generation stents, which are made of various metallic alloys. They are very thin, they go nicely into the artery, and they give us long-lasting results. But you might hear that after you've had a stent in, you are asked to stay on blood thinning medication for a lengthy period of time. We traditionally use aspirin, and that's one that we often use for life. And aspirin is a blood thinner that reduces the risks of clots forming inside the arteries, but also inside the stents. But we often find that aspirin is insufficient to help reduce the risk of clots forming inside the stents. And we often combine it with a different type of blood thinner, which is a little bit stronger than what aspirin is, but used in combination. And one of those medications you might have heard is called clopidogrel. That is a blood thinner that we use. Another one is ticagrelor. And these are newer generation types of blood thinners that we use to reduce the risks of complications developing inside the stents, particularly in the first 6 to 12 months as the body is getting acclimatized to having the stent inside. But over time, what happens is our body forms a nice amount of tissue to cover the stent. And that means that the blood traveling throughout and inside the stent is not visualizing any bits of metal in the artery wall, and it's less likely to cause a clot formation as a result of trying to reject the metal stent. Now, stents are continuing to evolve, and that's one of my key areas of interest in my research. I work across medicine and also biomedical engineering, and we are looking at what are the best types of stents for our patients into the future. Which stents are going to be better for patients, which stents might have less complications for patients, and which might be more compatible with the body. We've been looking at various materials, not only metal stents, but the newer generation stents potentially made of magnesium. See that the magnesium over a period of 18 months to 2 years actually breaks down and dissolves, potentially leaving nothing behind. So that's where I believe the future is going at a slow pace with our research. There are other devices we are working on that are made of polymers or plastic type materials rather than metal stents. Now, we know that the metal stents are typically there for life.
Here we have tofu.
No.
I won't touch this. Hi, it's Dr. Gundry here. Today I'm revealing which
Sorry about the
Polymer
ads.
stents, these stents open the artery up, but over a period of a few years, potentially there's a role that these stents will dissolve, break away, leaving the artery open. And that's really what we're looking at in terms of future research. There have been a few generations of these scaffolds or stents that have had some promising trial clinical data. However, the first generation, perhaps we're still learning a bit about, were associated with some slight increased complications. So now we're looking at second, third, and fourth generation scaffolds that potentially into the future, well, will form the mainstay treatment for patients. Now, when we place stents, we size them depending on your artery. Some of our arteries are large, and the typical size being about 3.5 millimeters in diameter to 4 millimeters in diameter. But the arteries have curves, have bends, are larger in one section than another. So at the moment, our stents are pretty much on the shelf with fixed measurements. They come in 2.5 millimeter diameter, 3, 3.5, 4, 4.55 millimeters in diameter. And the lengths can vary depending on the size that you need to treat for a particular blockage. But they are typically standard lengths, 12 millimeter, 16 millimeter, 20 millimeter, up to, 40 odd millimeters of stents, so 4 centimeters long. And sometimes we do need to use long stents to treat quite long parts of an artery that has got a lot of cholesterol. But I guess what excites me in terms of my research is, well, how do we actually tailor the stent or customize stents to fit individual patients? All our arteries are unique. No two arteries are the same. So we're looking at some very exciting applications of 3D printers and potentially taking very clear images of an artery, and these laser type scans that we use potentially could then provide us with an exact custom design that we could then print prior to implanting into patients. So that's not being done at the moment. That's purely a research avenue, but certainly holds a lot of promise and something that my team is working very, very strongly with across both in Australia, but also with international partners. So when you have a stent in, treatment isn't done. We have to maintain the stent, and that's really the paramount importance here of trying to control the underlying risk factors. Now, these risk factors, and as we've covered in previous videos, include high blood pressure, including high cholesterol, smoking, weight or being overweight, inactive, diabetes. These are key cardiac risk factors that we know if we don't control, problems will again develop, both in other parts of the artery, but also inside the stent. And there is a rate or a risk of complications developing inside stents that they can re-narrow, clog off. And that's why it is important that we do control risk factors. We do remain on a key number of medications. Now, again, I'm an advocate for minimizing medications, but we know that once a stent is in place, we need to be on a few medications long-term to maintain blood flow within the arteries and stop the process of build-up of cholesterol developing again. So there might be blood thinners, as I mentioned, aspirin, but there's a different type of aspirin that we often use in combination, typically for 12 months. But then there are cholesterol medications that we know have a dedicated impact on reducing the amount of cholesterol building up in other parts of the artery. But also we've seen new research emerging that cholesterol can also develop inside stents, a process known as neoatherosclerosis. So it's a process that we're learning a lot more by using these 3D images or scans inside the heart and the arteries to see that over time, cholesterol can actually build up inside stents. So it's paramount importance that we do work on those risk factors: nicotine, smoking, cholesterol, diabetes, blood pressure, keeping them all in check. Now, after the procedure, depending on how you've presented, and if it's not been an emergency, then often you can go home the next day. There is also some data to say that in certain situations, depending on where the narrowing is or where the blockage is, and depending on the level of support that you might have at home, there might be an opportunity for you to go home that evening. But typically, we usually stay the night. If you're presented in an emergency situation, whereby there might be a diagnosis of a heart attack where the artery's been abruptly closed and we've got to get in there at any time of the day or night to open up the artery, then you're often in hospital for a few days, being monitored and having your medication changed and monitored just to get you fit and strong, recovering, and probably go home after a few days. So again, hopefully I've given you some insights into what these stents are, why they are used, and obviously the key factors are trying to minimize the risks of stents failing or complications building up or new blockages developing. So Thanks for joining me, and I look forward to seeing you on the next video. Bye for now.
Small business.
No. Okay, hold on.
Great to be with you. It's Peter Barlas here, cardiologist. Now, one of the more common topics and videos that we've had as part of the channel relates to heart stents. And just a quick thank you to everybody that's clicked and watched it, and great to hear that you have found it useful. But a common question and comment that I often get asked is, how long do heart stents last? Well, answering that is like answering how long is a piece of string. There are so many variables that we can't provide you with a prediction. But what I want to do today is to go through 3 broad categories that we know lead to stents failing. So, as you would know, heart stents are little devices that are used to prop open blockages inside the arteries of the heart. They can be used at the time of somebody having a heart attack, or for patients who have stable symptoms called angina, where you might have pressure in the chest, shortness of breath, particularly up inclines, upstairs, with physical activity that is not responding to medicines. While stents can be useful to improve blood flow and therefore symptoms. And stents nowadays are very, very safe. The risks of stents are very low, but they're not zero. Anytime we implant a device permanently in the body, well, there are inherent complications that can arise. And to categorize these complications, I want to provide you with a framework of how I think about the topic of stents failing, or stent restenosis, where the stent develops this excess scar tissue inside, or stents can suddenly fail with a condition known as stent thrombosis, where that might be a bit more emergent and the risk of a heart attack is high if the artery fills up with clot at the level of the stent, and it's crucial that gets fixed up urgently. Now, I want to divide these complications and why stents fail in 3 categories. First, I want to focus on, well, the patient factors. So what are some of the factors that are relevant to the patient that may make the stent more likely to re-narrow? Secondly, I want to focus on stent factors themselves, so the devices that we're using and features of the blockage that we use to treat the problem. Well, there are some issues that can arise in stents as a result of the type of blockage that we are trying to open up. And thirdly, procedural factors. And they are factors, well, in short, they're factors relevant to the cardiologist that places the stent. And we'll delve into a few of those. So, patient factors. Well, why will stents fail? Stents will fail if we don't maintain them, if we don't look after them. And I often tell my patients that the easiest part of the stent is actually putting the stent in the first place, but then it's the many, many years and decades of life that we have to maintain the stent. And how do we maintain it? Well, we know that patients with diabetes are at a slightly higher risk of developing complications inside stents. So, of course, controlling diabetes appropriately, well, will significantly reduce the risk. We know that Patients with chronic kidney disease are also at a higher risk of developing complications inside stents. Patients who may not be compliant or taking the appropriate medication. And there are a series of medicines that we do prescribe after we use and we place a stent to help reduce the risk of the stent failing or developing a complication such as a clot formation. And these medicines often used to stop these clots forming, aspirin, clopidogrel, ticagrelor are some of the drugs that we use. And we use them for a specific purpose, in that in the initial phase, in the first few months of the stent being in the body, well, there is no tissue overlying the stent. It's a plain, metallic stent that's floating inside the artery of the heart. Well, we need to suppress the body's reaction against the stent and the risks of developing clots inside that stent as the stent heals inside the body. Well, these blood medicines, these blood anti-clot medicines are crucial that we remain on. And if we don't, well, there's a higher risk of developing a complication known as stent thrombosis, where the stent may block off. Also, not remaining on other types of medicines, and in particular, a couple of specific types of medicines have been shown to reduce the chances of building up cholesterol and blockages inside stents, and they are statins. So there's a lot said about statins, and I understand that there are people who have very, very strong views about statins. But there is a notion that if we can reduce the blood levels of cholesterol and therefore reduce the accumulation of cholesterol plaque inside, well, the region of where we've put the stent in the first place, we can reduce the risk of re-narrowing. And that re-narrowing is a process known as neoatherosclerosis, where new plaque forms inside the stent over time. And by taking statins, we significantly reduce that. The statins also reduce a process known as inflammation. And inflammation is also very, very important at causing cholesterol to become more active and to disrupt and to cause complications. Well, statins can reduce that. Managing blood pressure. So, of course, the higher the blood pressure, the more risk of developing re-narrowing inside stents, but also the risk of developing further blockages in other parts of the artery. So controlling that is paramount. Stopping smoking. Cigarette smoking is unfortunately one of the key factors that does lead to stents failing. Stents forming an excess amount of tissue or scar tissue inside can cause restenosis, and that can then bring on more symptoms. Chest pain, shortness of breath, and obviously has an impact on quality of life. So we know that cigarette smoking is a strong predictor of why a stent may fail. So there's some of the patient factors. Again, complying with medication, having diabetes, chronic kidney disease, smoking, not controlling blood pressure, not controlling blood levels of cholesterol, and not complying with medication. They are all factors that mean that you are a slightly higher risk of developing complications inside your heart stent. Now, the second part I want to focus on are stent factors or blockage or lesion factors. And these are factors that are relevant to your individual arteries and where the blockage is actually formed, and then the types of stents that we're using, because there are, we know, some factors that do lead to a slightly higher risk of stents failing. The type of stent, and we had a recent video on the differentiation between bare metal stents and drug eluting stents. Well, we know that with bare metal stents, where there's no drug coating around it that inhibits the body's reaction against the stent, there is a higher risk of re-narrowing and restenosis inside the stent with bare metal stents. It's not to say that we can't achieve excellent results with bare metal stents. We can, but we know time and time again that if bare metal stents are used compared to the more traditional now drug eluting stents or drug coated stents, then there is a higher risk of re-narrowing, and therefore bare metal stents are probably not indicated at present, given the great results that we're able to achieve with these drug eluting stents with a significantly lower risk of complications. So treating blockages that occur at bifurcation lesions, and we've had a separate video on bifurcation lesions themselves, and these are blockages that build up inside branch points of arteries. So when you have a blockage that forms in a rather complex part of an artery that has a branch point, while putting stents in that type of blockage versus a blockage that occurs in a single or a straight part of an artery with no branch, there is a slightly higher risk of complications and re-narrowing. Treating calcium or calcified lesions, when the arteries have got this material that essentially makes up our bone and our teeth, calcium,
it's a drill.
and over time that can build up and it becomes almost like a rock, a material that becomes so hard that we've often got to use very high pressure balloons to try to stretch and crack that calcium open so we can put stents in. But we often have to use these drills inside the artery to shave off some of the calcium to allow us to be able to expand the stent. Is that when we implant stents in these very calcified arteries, there is a slightly higher risk of re-narrowing, purely because of the forces that are exerted by the calcium can mean that these stents may be at a slightly higher risk of re-narrowing at that level of where the calcium is. Another site relevant to the arteries is if we put stents into arteries where there are bends, and not small bends, but when I'm talking about bends, I'm talking very sharp bends or kinks. And our arteries are all unique, but if blockages do develop in areas where the arteries are bending and we put a stent or a scaffold inside that area, well, you can imagine over time as the arteries beating every heartbeat and that motion of the coronary artery can often lead to a condition known as stent fracture, where the stent material starts breaking and starts fracturing. And that can be a reason why the stent can develop re-narrowing at that site and start giving you more symptoms. And finally, I want to cover factors that are associated with the procedure itself. And as interventional cardiologists, around the world, we strive to achieve an excellent result for all our patients. But there are some risks that are inherent with this procedure. So, for example, one of the more common reasons why a stent may fail in the immediate sort of few hours after a procedure, and you might have had the stent in and you had to go back and be rushed back into the procedure laboratory because you've developed significant chest pain and changes on your electrocardiogram, is a condition known as a dissection. And dissections are little tears in the walls of the artery that are initiated by us putting balloons and putting these stents inside the artery. And we create these microscopic little tears and trauma in the artery, but most often that heals and settles down, particularly when they are very, very microscopic and small. The body just heals naturally. But if these little tears occur at the edge of where we've put the stent in, and that tear is having an impact on blood flow, well, that can acutely cause a clot formation inside that part of the artery and inside the stent, meaning that we have to urgently go back in to put a further stent to cover that area that had that little dissection to ensure that can heal safely and achieve an excellent result long term. Another procedural factor is stents that are not sized appropriately to the artery. And that is a challenge. When the artery, for example, might be large in caliber, and all our arteries are very unique, but if the artery, for example, at the top part of the one of the key arteries of the heart is about 4 or 5 millimeters in diameter, and there's a blockage there. Well, we've got to ensure that we use the appropriate size stent to ensure that the stent is fully expanded inside that artery. If we use a smaller stent, a smaller diameter stent, well, then you can imagine that stent isn't fully expanding that large artery. And that is a reason why stents can re-narrow and why they can fail. And here's an example of an artery that has had a stent placed, but this was a relatively small stent that was put in. And over time, because of that mismatch in the size of the stent versus the size of the artery, there was a complication and restenosis, re-narrowing, about 90% blockage that developed inside, and they needed to go and put another stent to fix that up. So in this video, we've covered a few key factors that lead to stents re-narrowing or failing. This is a very complex topic, but an important one, and this, I hope, has given you some framework, some better understanding that putting the stent in, of course, is an involved process, requires your doctor to have the relevant experience to be able to size the stent appropriately to get a very good fit into your artery. But then there are also those additional factors of trying to, improve diabetes, reduce blood pressure, reduce the cholesterol levels in the bloodstream, stop smoking, and those key lifestyle factors that will ensure you achieve a stent that lasts forever. Thanks for joining me. I hope you found that useful. Until the next video, bye for now.
How the liver warns us that it is overworked.
Every single thing you eat or drink.
Yes, indeed.
Let's talk about the best meal that you could eat to help reduce plaquing in your arteries or even help prevent cardiovascular disease. Now, I've done a lot of videos on what to avoid to prevent heart disease. Today, I'm going to primarily focus on what to eat, okay? But we first have to give you a little background of what is going on behind the scenes as far as cardiovascular disease, and primarily we're going to talk about plaque. Now, what is in plaque? Plaque is a combination of calcium, protein, and cholesterol. Many times the calcium is the result of biofilms. So what's a biofilm? It's a colony of microbes that these microbes have built these little calcium igloos or shells to protect themselves so they can go underneath the radar. So when you see calcium plaque in the arteries, underneath that plaquing, there could be a microbial community. And biofilms tend to accumulate on roughened edges, right? If the arteries were nice and smooth and strong, they probably would never accumulate on the arteries. But the question is, what causes them to get stuck on the inside of the artery wall, in your coronary artery, for example? Well, that would be some type of, they call it lesion or oxidation or inflammation or damage from excessive sugar in the diet. It could be you're diabetic, you could be a pre-diabetic, it could come from omega-6 fatty acids, junk foods, alcohol, all sorts of things. So when you see plaquing, you're also going to see this LDL, a very specific kind, the small, dense particle size. And that's correlated too with a high sugar, high carb diet. And some of this cholesterol in this little package, and that's what the LDL is, it's a protein that carries cholesterol. Cholesterol doesn't exist as cholesterol in the arteries like free floating. It's always in a little shuttle bus. But the cholesterol is coming in the form of Band-Aid with the cement, the calcium. And then also you're going to get fibrous tissue, like a protein cement that kind of mixes in with the calcium and the cholesterol as a Band-Aid. And then you'll see like a thrombus or a clot forming too in that same area. So given that information, what can we do to prevent, slow down, or reverse this situation? All right, there's several things to know about this. One of the controlling vitamins with calcium is vitamin K2. Vitamin K2 drives the calcium into the bone. Without enough K2, calcium tends to develop in the soft tissues of the body, not just your arteries, but also in the joints as well. And there's one more point about biofilms. There's some interesting things about biofilms, especially when we're dealing with plaquing in your arteries. There's several studies that I found that links periodontal bacteria, the bacteria in your mouth, this pathogenic bacteria actually ending up in the plaquing in your arteries. I mean, that's interesting because what are these periodontal bacteria, they're pathogenic, they're in your mouth, doing in your heart, okay? Now, you have to realize, like, in the mouth, you have over 700 different species, okay? Not just bacteria, but different types of bacteria in your mouth. And one of the reasons why the bacteria can actually go through the pores, through your gums and into your bloodstream is the same reason why bacteria can leak from your intestines into your bloodstream. That's called bacterial translocation, where bacteria is moving through the wall. They might get bleeding gums. So that allows the microbes to go right through these little holes into your bloodstream. So high vitamin C foods are definitely necessary for this meal. So foods with large amounts of vitamin C would also be a good thing. Then we have vitamin E, okay? Vitamin E in relationship to keeping your cardiovascular system intact is very, very important. First of all, it helps prevent those lesions on the inside of the wall of the artery called endothelial tissue. When you're low in vitamin E, which is a very powerful antioxidant, you can get a lot of oxidation and inflammation. So vitamin E is very important. Also, it's important in the heart muscle itself, keeping your oxygen high and preventing an actual heart attack. So we have vitamin K2, very important, vitamin C, very important, and vitamin E. And the other important thing with the heart, especially to avoid that lesion in the artery, is to keep your omega-6 fatty acid very low and keep your omega-3 very, very high. So a really important thing in this meal should be omega-3 fatty acids, okay? All right, so what should this meal look like? Well, let's start from the top, omega-3 fatty acids, okay? What food is very, very high in omega-3? And that would be wild-caught salmon. So if you include salmon in this meal, okay, you're going to have a good amount of omega-3 fatty acids, which is going to support the arteries as well as the heart muscle itself. And having enough omega-3 will decrease your inflammation as well in your arteries. And doing that can actually lower blood pressure as well. All right, there's something else that I think is very, very important in preventing and even maybe reversing some of this plaquing in the arteries. This thing has like 7 times the requirements of vitamin C. It also is one of the most microbial dense foods that you can eat, giving you a strong probiotic effect with high levels of lactic acid bacteria. Now, let me just kind of discuss lactic acid bacteria. It's not just one bacteria. It's a group of many different types of bacteria that is usually involved in fermentation. And so the food that I'm talking about is sauerkraut, okay? That is a fermented cabbage product. And sauerkraut is loaded with this lactic acid bacteria. And lactic acid bacteria as a standalone thing is very interesting because it can act as an ACE inhibitor to help lower blood pressure. It can inhibit biofilms, which is very, very cool. It can decrease the risk of cardiovascular disease by supporting your gut. There's a huge relationship between a healthy gut with the right microbes and a healthy heart. Also, this lactic acid bacteria can help regulate LDL cholesterol, especially the small, dense particle size LDL. And having enough of this lactic acid bacteria can enhance your production of secondary bile salts, which can help the absorption of more vitamin E, vitamin D, and vitamin K2. All 3 of those are fat soluble and can greatly support the cardiovascular tissue. And it just so happens that sauerkraut is loaded with vitamin K2. Now, normally vitamin K2 is in like certain hard cheeses, fats, but microbes can also make K2. Just to summarize what sauerkraut is, it's a superfood for the heart. It supports the gut lining to prevent these microbes from traveling through a leaky gut up into the heart. It has many different diverse types of microbial entities that can greatly help you in many different ways. And then sauerkraut's loaded with vitamin K2 to keep the calcium out of the arteries. It's loaded with vitamin C, like I said before, 7 times the RDA. So that gives you a tremendous amount of vitamin C that can directly inhibit biofilms as well as act as an antioxidant in the arteries, preventing these lesions or damage to the wall of the arteries. Remember, the biofilms can only stick to an area that's roughened or irritated. So if your arteries are smooth, they can't quite stick to the inside of your arteries to form the plaquing in the first place. And the last part of this meal is a big arugula salad with several things in it, which I'm going to cover. But arugula as a vegetable is a superior salad green compared to regular lettuce because, first of all, it's cruciferous, so it's really good for the liver. It's bitter. It has blood glucose lowering properties. It's loaded with something called DIM, which can help lower biofilms directly. It also has fiber to feed the bacteria, and it's also loaded in potassium, which can help keep the arteries softened so your blood pressure can stay normal. And then, of course, on that salad, I would put extra virgin olive oil, the real stuff. It has significant effects on blood pressure. Not to mention
The Wells Fargo Active Cash Card. Earn 2% cash back on what you want, like a 22-speed road bike. And need. Like a ride back from your ride.
Sorry.
It's West.
Not to mention, it has very powerful anti-inflammatory effects as well. Then I would also add apple cider vinegar, but you can also use balsamic vinaigrette. But the acetic acid in the vinegar has many properties to help lowering the risk of cardiovascular disease. It's great for helping regulate your blood sugar. It can help regulate your cholesterol. It can help mobilize your bile salts, and it has anti-inflammatory properties. And then if you add sunflower seeds, okay, we can spike more vitamin E. And like I said before, vitamin E is very, very important. Now, the next thing I'm going to talk about is a hard cheese, okay? Hard cheeses are loaded with vitamin K2. And the type of cheese I would recommend is called Parmigiano. Now, I probably did not pronounce that exactly like I should, but the American translation from Italian is Parmesan. But apparently there's been a lot of lawsuits involving this topic because apparently Kraft trademarked this English translation from the real Parmesan cheese in Italy because the real Parmigiano version of that cheese is only produced by a collective group of farmers in northern Italy that keep their standards very, very high. And this has been going on since the Middle Ages. It wasn't until only fairly recently that Kraft came in there and started to make it. But unfortunately, there's a big difference in how they make it in America versus how they make it in Italy. In Italy, they age it for like 1 to 3 years compared to in America, I think they age it for 10 months. And the Kraft's version of this cheese definitely does not have to abide by the same policies and rules and laws than the authentic cheese in Italy has to abide by. And the other thing you have to watch out for in this Americanized Parmesan cheese is that sometimes they add this filler of cellulose, okay, which is wood pulp. So what I would recommend is get the authentic type from Italy and shave it on your salad. I do it every single day. That way you have a delicious cheese that's loaded with vitamin K2, and it's a great amount of protein. There's probiotics in this product, and it's an incredible product. I actually went to one of the farms where they create this cheese, and I was blown away at what they feed the cows to make sure the microbes are just right, and the soils that they grow the grass on or the cows, they don't get fed grain, it's all grass. And the amount of work that goes in to make this cheese and keep it a really standard process is mind-blowing. And the last thing I'm going to recommend to put on your salad is garlic. Okay, you can use powder, you can use actual garlic, you can use fermented garlic, but garlic is great for the heart. It actually can thin the blood. If there's a chance that you are at high risk for clotting, it can help lower your blood pressure. It's antimicrobial, anti-biofilm, and the list goes on and on. All right, so now that you have that information, I think the best, most interesting next video for you to watch would be the one on biofilms in your mouth. Check it out. I put it right here.
Okay, we are going to stop. Stop. And exit. Okay. So, what did you think?
I thought that they were both really interesting. I mean, the information about stents, I don't think most people know those issues about choosing the right one, for example, or sizing it properly, all the things that you might want to ask about, and how to maintain them. It was just incredible. And the other video about was really short, but to give an idea about how important prevention is to start with and to maintain with diet and supplements. I mean, I think that's just essential, and it's such a good reminder, because we all probably have some of that in mind, but how often do we do it? It's just was so great. It was inspirational, so good information.
Thanks, Sally.
Yeah.
Anyone else?
I have to change my cheese shopping.
Yeah.
I know. Well, and I just was so impressed with how both speakers, but Dr. Barlas in particular, was able to get across major concepts. And I thought both of them used graphics to great effect. Just, to explain one particular concept or whatever. And I feel the same way about the salad, but
Yeah.
sauerkraut, really? Oh, not on my favorite list.
And that's true, though, with any kind of fermented food. So there are a few other things that have the same properties, but they're all pretty sour, I think. Like miso, I guess is it Japanese, or I think it's Japanese. Miso is an excellent, supposedly fermented food, and kimchi, or that's similar to sauerkraut, but there are other ways to look for any fermented food does those things. From what I've read, I read a lot about that kind of thing.
And back to Dr. Burles, he seeing that little tiny drill that go through and try to bore out the calcium, that was amazing to see that they can do that. See, I got that there was cholesterol in your arteries, but I didn't understand the calcium, and that package of 3 things that all bind together was very helpful for me in understanding why calcium is not bad, but you want it to go to your bones and not to the soft tissue. So that was very helpful to find out that that's how to do it. They didn't really address too much about the calcium score. Has anyone heard about that?
Yeah. I found out about that for the first time before I had surgery, because it was, even though my surgery wasn't arterial, it was required to know whether there was cholesterol. And so I had no idea that it was measurable, and that not just hoping that you're taking a statin or doing other things that are preventing cholesterol buildup, but that you can actually see with doing an angiogram of some sort. There are different kinds, I guess, but that you can see whether you have dangerous calcium buildup or not. It's getting, out of hand. I think would be great if it were more available as a once in a while, not maybe every year, but as a maintenance tool for following, if you're doing a good job with keeping cholesterol down. And so it's
Yeah,
I've been
I'm
interested
going
in.
to ask to see what my score is. I did find out in watching some of the other videos on the calcium score
Oh.
that you shouldn't be put off if it's high. You're supposed to, you're supposed to have 0, but
Mhm.
that's not going to happen because most scoring is your whole body. So that's outside of the inside of the arteries, right? So there go your bones and all, that's included in this calcium score.
They
So
would just be estimating it in that case, though, because they're really reading what they see in the
exactly. Yeah.
artery.
And so they're trying to take a percentage of what all of your calcium
Mhm.
is.
Yes.
Anyway,
Good
it
point.
was enlightening to realize that although it's a nice marker, but there were people getting just terrified at their calcium being so high, and then not realizing that it's a very imperfect measurement until they, find a better way to do it.
Mhm.
I was also impressed that they did talk about the dissection, because that was what I had. They said my stent came loose. It wasn't put in all the way, right? Wasn't squeezed, into the
Huh.
walls, and the edge had torn the wall apparently, and that had caused a stent or a clot.
Oh.
So that was I was glad, to find out that there are some that it's something that happens, but it's not. And I asked him, I said, well, can't you replace the stent? Take the bad one out and put a new one in. And they said, not unless you want to do open heart surgery. Because if we tried to drag it back through your arteries, it would just shred the walls. And so I'm like, okay, never mind. Just put it back in.
Yeah. Oh, it's interesting.
The stent is basically a Mexican finger puzzle. Once it's opened, you can't pull it back out.
An interesting way to look at it, right?
Yeah. And I also I had no idea that there was such a thing as a vitamin K2, and that's especially what takes the calcium out of the soft tissue and lets it go into the bone. Why have I never heard of this? So
doctors don't talk about it, that kind of thing. You can buy vitamin K2 as a supplement as well, and kind of, especially if you've got consulted a nutritionist or someone who could, work with you on potencies that are helpful. It's probably a good one to consider.
I think I'd rather do that than sauerkraut.
Right. Yeah, that's another thing.
Maybe I should revisit it before I just turn my nose up, I think.
Yeah, it's too bad there aren't more things that that have that besides sauerkraut or those foods. But
well, and I love salmon, so that's okay.
That's good.
I thought it was interesting that he designated wild salmon. So much salmon that is in the markets is not wild.
Very little anymore.
Yeah, I order it through the through online.
You do? That?
Yeah. Yeah, it's
Oh,
fun.
that's an idea.
But there are several places that offer
Oh, okay.
wild caught salmon. Well, thank you each and all for seeing this wonderful program. I'm glad it will be. Oh, we're still recording. Sorry, I should turn that off. Oh, I guess I don't do it.
I'll turn it off now if you want.
Yeah, thank you.
Great.
That way, it'll be up on our channel in about a week, so we can have it there for all the people who didn't watch.
Yeah.
So,
Okay, well, thank you, Laura.
yeah,
Thank you. A lot of
Yeah.
good information.
good. Well, I look forward to working with Neil. I'm just so excited to have him be joining the team and
that's
helping
great.
to do some of these great shows.
It's gonna be great.
All right, everybody, hydrate. It's going to be hot.
Yes, everyone, yes.
Laura, can you share the links to those videos on YouTube? I found one, but I didn't find the second one yet.
Oh, I'd be glad to. Does anyone else want them? The links to the
I
videos?
I
have.
mean, I don't want to wait a week.
Okay,
It's
All
very
right.
dense and very relevant to my situation, both. So,
okay. Well, I'll be glad to share them, and if anyone else wants them, I could share them to you too. Okay, well.
Okay.
Thank you. Get those to you, sorry, Neil.
Yeah.
Bye-bye.
Bye.
Take
Thank
care.
you.